Hello, my name is Kiran Lagisetty from the University of Michigan, and today I'll be discussing surgical decision-making in the immunotherapy era. The learning objectives from today's talk are we're going to discuss which tumors are resectable and have indications for neoadjuvant therapy and some of the controversy around determining resectability. We'll discuss how neoadjuvant therapy, specifically chemoimmunotherapy, has impacted how we perform lung resections. Lastly, we'll discuss some of the postoperative considerations for patients undergoing resection after undergoing neoadjuvant chemoimmunotherapy. The current guidelines exhibit significant variation in resectability criteria, and the recently completed and ongoing studies lack mention of resectability determination in their inclusion criteria. Given the lack of consensus, it makes identifying patients who may be candidates for these therapies very difficult. Locally advanced lung cancer typically refers to tumors which are clinical stage 2 or 3. However, as you can see from the most recent ninth edition staging guidelines, this represents a large swath of clinical T stages and N stages. Therefore, all stage 2 and 3 tumors may not all be biologically the same. Because these stages are made up of so many different T and N subsets, this is what leads to difficulty in determining what is resectable disease. Recently, two groups put forth consensus guidelines regarding which subsets of tumors were considered resectable. The left-hand panel are the results from the European Organization for Research and Treatment of Cancer, who performed a Delphi panel, which was published earlier this year. The group administered surveyed to practicing thoracic surgeons, radiation oncologists, medical oncologists, and pulmonologists. Each respondent would answer resectable, unresectable, or maybe for each T and M subset. A percentage of 75% was used as a threshold for agreement on recommendation. This group of 558 respondents were only able to agree on one TNM subset for resectability, the T3N1 subgroup, and multiple TNM subsets for patients who were unresectable. However, most subsets were considered potentially resectable or no agreement could be reached. Similarly, the Society of Thoracic Surgeons put out consensus guidelines on which TNM subsets their expert group considered resectable. The two groups had some overlap in guideline recommendations. However, there still remains some areas of differing opinions. Both groups consider T3N1 disease resectable. However, there was still variability in subgroups of which patients with single station N2 disease and single station N2 disease with bulkier nodes. So back to this question. Who should be considered for surgical resection with locally advanced lung cancer? And the answer is it depends. Patients with locally advanced lung cancer should all be discussed in multidisciplinary settings with significant surgeon involvement. In today's age, locally advanced patients need to go through diagnostic workup, staging, and molecular classifications in order to receive the best evidence-based treatments. For surgeons, they should consider the following. The ability to achieve R0 resection. We know from existing data that the best long-term outcomes are from patients who are able to undergo an R0 resection. Two, the ability to perform resections with acceptable morbidity. Given the incredibly low rates of morbidity from lung cancer resections, every effort should be made to ensure patients are able to undergo a safe operation, specifically minimally invasive operations when able. And lastly, biologic considerations. This means patients who are deemed non-surgical should not be given neoadjuvant therapy with the intent of downstaging towards resection. The most recent chemoimmuno trials have given us some insight on surgical outcomes for patients undergoing neoadjuvant therapy. The most striking consideration is that 15 to 20% of patients do not make it to surgical resection. Surgical delays must be anticipated, especially when patients experience adverse events such as pneumonitis. Oftentimes, this complication can be associated with steroid administration, and timing of surgical resection should be planned around administration of steroids. Neoadjuvant trials have also demonstrated disease progression can occur in up to 10% of patients, and this can render patients non-surgical or make intended surgical resections more difficult. The most difficult aspect of neoadjuvant therapy to quantify is the inherent inflammatory reaction which occurs after therapy. Sometimes these effects can be minimal. However, for many patients, inflammation and fibrosis can lead to increased surgical difficulty, which leads us to optimal timing of surgical resection. Most studies have advocated for surgery to occur within 4 to 8 weeks after completion of neoadjuvant therapy to perform resection to balance the immune-related inflammation and fibrosis. Recent trial data demonstrates those who do make it to surgery, about 13 to 25% will have delays in care, with an average delay of 2 weeks, with around 20% of patients not even making it to an operation. More than half the patients underwent a thoracotomy, with approximately 10 to 20% minimally invasive to open conversion rate. These rates of thoracotomies have been pretty consistent across various trials and have been performed to date, and most of the early trial data demonstrated planned thoracotomy rates about 40 to 50%. These studies show relative low 90-day mortality, high rates of R0 resections ranging anywhere from 70 to 96%. Recent single center studies have consistently shown R0 resection rates in the 90th percents. As you can see, about 20 to 60% of patients can have grade 3 or 4 adverse reactions, which can further complicate surgical resection, especially if complications include pneumonitis. Emerging literature from trial data and real-world experience demonstrates that neoadjuvant therapy does result in more technically difficult lung resections. Minimally invasive approaches can and should be utilized. However, surgeons should be ready for technically challenging operations, which may require open and advanced resection techniques such as sleeve lobectomies, arterioplasty, bilobectomies. Experience is critical for good surgical outcomes. Surgeons should know when to convert. Fibrotic tissues are fragile and dissection must be very meticulous and careful. Patient fitness should be prioritized and ensure good technical outcomes. When we think about postoperative complications which occur, these can happen after any lung resection. However, patients undergoing neoadjuvant chemoimmunotherapy are particularly prone to adverse events, considering some may experience physical decline following immunotherapy administration. Therefore, preoperative optimization is key to successful outcomes postoperatively. Immunotherapy can lead to side effects such as pneumonitis, adrenal insufficiency, and thyroid dysfunction, and these side effects have the potential to increase risks of postoperative complications. Pneumonitis in particular can mimic an infection and may require steroids for treatment. Currently, there's limited data around postoperative complications. Most of the trial data focus on conversion rates, blood loss, operative times, and length of stay. However, recent large trials have shown complication rates about 15 to 40%. We are starting to see some institutional data around center-level experience with these types of resections. The summary to the right of the screen demonstrates adverse outcomes reported in several recent clinical trials, which shows the main described complications were pneumonia, bronchopleural fissure, prolonged air leak. The difficulty in determining rates of postoperative complications is difficult given the heterogeneity of the studies, given the side effect profile of the different therapies. Patient adverse events and surgical expertise at each treating center has also made understanding these complications difficult. Emerging treatments options for locally advanced lung cancer have changed our conventional treatment paradigms. With neoadjuvant chemoimmuno treatment, there's potential to increase technical difficulties of these lung resections. However, recent trial data suggests equivalent outcomes in patients receiving chemo or chemo with immunotherapy. This underscores the need to carefully select patients for resection in a multidisciplinary fashion with input from experienced surgeons. Surgical resection approach should be based on technical skill level and may require open operations. In addition, surgeons should be comfortable with advanced resection techniques. Lastly, surgeons should be aware of unique postoperative complications, which may arise from immune-related toxicity, especially around the management of pneumonitis.